It's a pleasure to be here, and I'd like to thank Myeloma Hub for the invitation. Look, optimizing this treatment strategy is a topic close to my heart because a drug use in clinical trials is very different from how we use it in the real world, where often thoughtful balancing act is required to balance efficacy, safety, and long-term quality of life. Next slide, please. Now, as our experience with BCMA therapies grow, we know that dose modification is absolutely essential to optimizing outcome, particularly given the distinct adverse profile of these agents. So unlike a CAR T cell where toxicity management follows a one-time infusion, bispecific antibodies and antibody drug conjugates are given continuously. And in this sense, it is important that dose optimization is just not about minimizing toxicity, but it's also about maintaining patients on effective treatment for longer, thereby preserving efficacy. And this is particularly important for the relapse refractory population where patients are older and frailer, because we know that in this particular group of patients, treatment-related toxicity and early treatment discontinuation are independently associated with poorer outcomes. Next slide, please. So this slide here basically summarizes the recommended dosing schedules for the approved BCMA-targeted therapies. Teclistamab and elranatamab are given subcutaneously weekly after step-up dosing, and for teclistamab, a step-down dosing to every 2 weeks upon achievement of a complete remission for at least 6 months is recommended. And given the median time to complete remission in Majestic-1 of roughly about 5 months, this ends up being roughly at 1 year. Elranatamab transitions to a bi-weekly dosing much sooner in responding patients after roughly 24 weeks, and then to every monthly after another 24 weeks. Dose reductions are generally not recommended for bispecific antibodies, but rather dose delay. Now, for belantamab mafodotin, or belamaf, the EMA recommended dosing strategies closely mirror that of the DREAMM-7 and the DREAMM-8 studies respectively, so Q3 weeks together with bortezomib and dexamethasone initially, and then for DREAMM-8, it's Q4 weeks together with pomalidomide and dexamethasone. Now, in real life, the dictators of dose modification is often ocular adverse events, which is often reversible. And in real life, these dosing strategies are often adapted to preempt these ocular adverse events. Next slide, please. So let's first look at the impact of dose modification on clinical trials outcome. Next slide, please. So with belantamab mafodotin, the outcome for the DREAMM-7 and DREAMM-8 studies are very similar in that ocular events were commonly managed using dose modifications, and this enabled many patients to continue on with treatment. And with time, we saw that the median dosing interval of belamaf gradually increased to about 12 weeks in both trials, and with this, the incidence of clinically meaningful reduction in the visual acuity decline gradually decreased, as you can see in the pink line, and the incidence of discontinuation was quite rare, as you can see in the black bar there. What's important is that despite these dose delay, response deepened, and overall, the median progression-free survival of those patients who had a dose delay for at least 8 weeks were very similar to the overall patient population. So in short, dose delay for belamaf did not impact on its efficacy. Next slide, please. With teclistamab, the Majestic-1 study initially treated patients weekly until disease progression. And as you've heard from Frederick, this was associated initially with high early rates of infection. Later on, the protocol was amended to allow deep responders to transition to a 2-weekly dosing. And here you can see that with longer-term follow-up, we do see a decreased incidence of grade 3 infections over time after roughly about 12 months. And this coincided with the time or the median time to the Q2 week dosing strategy. And interestingly, real-world data with teclistamab would suggest that roughly 25 to 40% of patients do undergo early dose de-escalation after median time of roughly 3 months, as opposed to after the 6 months of at least in CR per labeled directions. And the main drivers for these were adverse events and frailty. Next slide, please. And similarly, with elranatamab, an ad hoc analysis of 27 patients in the MAGNETISM-3 study who managed to transition to every Q4 weekly dosing, you can see here that while the incidence of mild infections were very similar, yet the incidence of grade 3 or 4 or severe infection did decrease from around 18% down to around 11%. So, granted the limitations of our ad hoc analysis, the common theme that seems to come through with many of these studies is that dose modification strategies with bispecific antibodies are associated with reduced incidence of higher grade infections. Next slide, please. So how does this all impact on long-term quality of life? Next slide, please. So this slide here summarizes the patient-reported outcome with belantamab mafodotin in the DREAMM-7 and DREAMM-8 studies. On the left are the percentages of patients who reported at least a 1 severity or interference score post-baseline of blurry vision or fatigue, which are the 2 common symptoms in the DREAMM-7 and DREAMM-8 studies. And in the right table, you will see that despite common blurry vision, the impact on health status and quality of life was quite modest, and the vision-related functioning either improved or maintained throughout treatment. Now, in contrast, fatigue or decreased appetite, which are the 2 very common symptoms associated with myeloma in general and its treatments, have a stronger association with negative quality of life. But overall, with appropriate protocol-mandated dose adaptation, we see that the quality of life of patients do improve or were stable over time with belantamab combinations across multiple domains with time. Next slide, please. And with teclistamab, now the MajesTEC-1 study did show the initial decline in some of the reported domains, often associated with CRS and initial step-up dosing, but this was transient. What we do see from data at cycle 12 is that there were a significant proportion of patients did report a clinically meaningful improvement in quality of life across multiple domains, including cognitive, emotional, physical, and social functioning, as well as 2 key symptoms, including pain and fatigue. And importantly, the quality of life as assessed by the visual scale demonstrated that there was also clinically meaningful improvement reported in the majority of patients. Next slide, please. And similarly, with elranatamab, in the MAGNETISM-3 studies, there was also an earlier transient worsening of treatment-related side effects associated with CRS and step-up dosing. But overall, elranatamab did show an early patient-perceived improvement with no evident long-term quality of life impact. The diagram that you see there summarizes the change in symptoms reported in BCMA-naive patients on the left and BCMA-exposed patients on the right. And you can see that there is an improvement in symptoms, much better in pink and a little better in navy, in a significant proportion of patients, 40 to 50% of patients, as early as cycle 1, day 15. And the percentage of these patients increased with time. So overall, what we do see is that there is an improvement in quality of life with prompt disease control, which tend to occur very early with all the BCMA-targeted therapies. And so it is important that we must not compromise these gains by the cumulative toxicity that is associated with ongoing treatment intensity. Next slide, please. So in summary, BCMA-directed therapies are associated with a distinct adverse event profile that do require proactive monitoring and management. Dose adaptation is very important, not only to improve tolerability, but importantly to allow patients to remain on treatment and thereby preserving efficacy. dose modification and delays are absolutely crucial in managing the ocular adverse events associated with belantamab mafodotin. And similarly, dose delay are very important in managing the side effects associated with BCMA-directed bispecific antibodies, and extending treatment intervals has been associated with a reduced incidence of severe infections. And so overall, with thoughtful and personalized dosing strategies, BCMA-directed therapies overall are associated with a generally stable or improved quality of life over time, and their treatment-related side effects should be quite manageable.